So here's question 1. A 35-year-old man with bipolar disorder is treated with lithium, and he gets referred to you for chronic polyuria and polydipsia. He complains that he's having to void once every hour. His serum sodium is 146, creatinine is 1.9, serum osmolality 305, 24-hour urine volume is 5 liters, urine sodium 28, urine osmolality 190. And the question is, which of the following might be appropriate in the management of this patient? Is it stop the lithium, give demeclocycline, give a vasopressin V2 receptor antagonist, fluid restriction, or furosemide? All right, good. So most of you chose A, which is discontinue lithium, which is the correct answer. Some of you chose D, which is fluid restriction, which is not correct. So let's go over this very briefly. So this is, again, the algorithm that I showed you earlier this morning. Patient is hypernatremic. The first question is the urine osmolality appropriately concentrated or diluted? So this patient's urine osmolality was 190, which is inappropriately dilute. So this is a patient that has renal water loss, either from diabetes insipidus or osmotic diuresis. There's no other information given in the case that will allow you to distinguish between the two. If this were renal boards, they might give you the components of the urine. For the purpose of the internal medicine boards, they would not, but they would expect you to recognize that lithium is an extremely common cause of nephrogenic diabetes insipidus, and often also associated with chronic kidney disease, as in this patient. So that's by far the most likely diagnosis. In terms of the treatment, if we just go over the options available, stopping the lithium can correct the disorder in many patients. In some patients, the nephrogenic diabetes insipidus is permanent, but you certainly would want to try and discontinue the lithium. Demeclocycline and vasopressin antagonists are wrong. They're used for the treatment of hyponatremia, not hypernatremia. They would do the opposite. Fluid restriction is probably not a good idea in a patient with diabetes insipidus. So the reason that most patients with diabetes insipidus aren't in hospital basically 24 hours a day, 7 days a week, is because while they're excreting this dilute urine, they're drinking enough water normally to be able to correct their sodium most of the way back to normal. So oftentimes patients with diabetes insipidus don't present with hyponatremia until they're stopped drinking. So someone who comes into hospital for surgery and they're made NPO overnight, then their serum sodium can rise quite dramatically. So fluid restriction is in fact the wrong thing to do in this patient. And furosemide again is treatment for hyponatremia, not hyper. Okay, number 2. An 85-year-old woman who lives alone fell in her bedroom and broke her hip. She's unable to get up and has no access to water. She's found 2 days later and brought into the ER, at which time she's drowsy but responsive, has a lowish blood pressure, tachycardic, weighs 70 kilos, mucous membranes are very dry and skin turgor is decreased. And her serum sodium is 164, BUN's 54, creatinine 1.2, hematocrit 56, and urine osmolality 820. And the question is, which of the following statements is false? So this sort of question comes up in the boards where they try and trick you by pointing out which one's false. So you really have to read these carefully. She has intracellular fluid volume depletion. Appropriate initial fluids would be half normal saline. Her serum sodium should be lowered to a target of 152 in the next 24 hours. Overly rapid correction of her hypernatremia could cause osmotic demyelination syndrome, and correction of her hypernatremia could cause cerebral edema. Which one is false? Okay. And okay, so 40% chose D, which is in fact the correct answer, and a quarter of you chose B, which turns out to be true, and I'll explain why in a second. So firstly, this is a patient whose urine osm is high, So obviously the hyponatremia is caused by some extra-renal cause of water loss. And because of the clinical history, it's pretty obvious that this is insensible losses in a patient who has no access to water and therefore has decreased water intake. So the other question that we have to address here is what's the appropriate treatment in this patient? A is she has intracellular fluid volume depletion. So in a patient who's hypernatremic, they're not only extracellular fluid volume depleted, but they're intracellular fluid volume depleted. In fact, in hypernatremia, there is a shift of water from the intracellular to the extracellular fluid. And so they're actually disproportionately intracellular fluid volume depleted. This is important to remember because the opposite is also true, that when you correct the hyponatremia, there's a disproportionate shift of fluid back into the intracellular space, and so you can cause cerebral edema, and that's why E is correct. So A is correct and E is correct. Let's go to C first. Where should the serum sodium be lowered to? So one common recommendation is to correct half of the deficit in the first 24 hours. So going down 12 to 152 in the first 24 hours is entirely appropriate. So C is correct. What about B? Well, clearly this patient needs free water, okay, and just pure free water would be 5% dextrose. But because this patient is also showing evidence that their blood volume is profoundly low, so this patient is hypotensive and tachycardic, you'd want to give the patient some saline as well. So you can either give isotonic saline and give additional free water, or you can give something that's a mixture of the two. So half normal saline would be a perfectly appropriate fluid in this patient. So half normal saline, 1 liter of half normal saline is basically the same as half a liter of normal saline and half a liter of pure water. So it would both help to raise the blood volume and also dilute down the serum sodium. And that's why B is actually correct. So the only one that's false is D. Osmotic demyelination syndrome happens when you correct hyponatremia, not hyper. So don't get confused by that. Okay, so number 3. This is a 64-year-old woman with CAD, multiple MIs, ischemic cardiomyopathy, EF of 15%. She comes in with pulmonary edema. She's on the usual slew of cardiac meds. On exam, blood pressure is 97/54, heart rate 85, JVP 9, crackles in the lungs, S3 gallop, cold clammy extremities, and edema. And her serum sodium is 128. Let's see. BUN 46, creatinine 1.2, bicarb 34, pH 7.48. And her urine electrolytes, when she's not on a diuretic, shows the urine sodium is 15, urine chloride less than 5, urine osmolality 220. And the question is, all of the following might be appropriate in the management of this patient except. So this is another one of these is false. And the rest are true. IV isotonic saline, restriction of free water intake, dietary sodium restriction, dobutamine, acetazolamide. And most of you said A, which is absolutely correct. Some of you picked E, which was sort of a little red herring for you. So obviously this is a patient who has an edematous state, CHF, and has hypoosmolar hyponatremia from that. And the expectation with that is that your urine sodium or chloride will be low and your urine osmolality will be high, which hers is. The question is, how would you treat that? You can try and increase the cardiac output, so that will obviously help perfusion of the kidneys, whereas normal saline probably wouldn't help in this case because this is not hypovolemia causing hyponatremia. In fact, this patient is clearly volume overloaded, so normal saline would not help. Restriction of free water intake, always useful in treating patients with hyponatremia. Dietary sodium restriction would help with the CHF. Note that these two are sort of acting against each other. So this is one of the challenging things in the management of patients with CHF. You don't want them to get too much sodium because that makes their cardiac failure worse, but obviously that would worsen the hyponatremia, so you have to restrict free water intake even more. Acetazolamide is sometimes useful in patients who are alkalemic and have volume overload. So this allows you to diurese the patients while correcting the alkalosis. Acetazolamide is a carbonic anhydrase inhibitor, and it has relatively mild effects on the serum sodium. So E is probably fine, so saline is probably the only thing that wouldn't be a good idea in this patient. Okay, next question. A 45-year-old male smoker presents with confusion and drowsiness. His only meds are a bronchodilator and steroid inhalers. On exam, he basically looks euvolemic, and the chest radiograph just shows emphysematous changes. And his serum sodium is 116, serum osmolality is 256, urine sodium is 85, urine osmolality 670. And so appropriate steps in the management of this patient might include order serum protein and lipid panel, CT scan of the chest, site consult, administer a thiazide, or order an echo. And most of you chose CT scan of the chest, which is what I would agree with. So this patient obviously has hypoosmolar hyponatremia. The plasma osmolality was low. So this is not going to be pseudohyponatremia, and so this lipid or protein panel is not going to help you there. This patient is euvolemic, and the urine osmolality is high. In fact, it's very high. Generally, when the urine osmolality is very high, meaning more than about 400 or 500, most of those patients are going to have SIADH. You always would want to check the TSH and the cortisol, as I mentioned, but the most likely diagnosis in this patient is SIADH. The urine sodiums are usually high in SIADH, which his was. And given the whole clinical picture, you'd certainly want to suspect a small cell carcinoma of the lung, probably the commonest cause of non-drug cause of SIADH. And so CT scan of the lungs would be perfectly appropriate in this patient. Okay, number 5. So this is a 45-year-old woman with hypertension and type 2 diabetes mellitus who's presenting with leg swelling. And her meds are insulin, amlodipine, enalapril, furosemide, and aspirin. And she has a potassium of 6.2, bicarb of 20, creatinine of 1.9, and 4.8 grams of protein in the urine. And the question is, all of the following could be contributing to this patient's hyperkalemia except, so one would not be contributing. And is it enalapril, decreased GFR, type 4 RTA, renal artery stenosis, or excess dietary K intake? Okay, all right, interesting. So most of you chose D, which is the correct answer. Some of you chose C, probably because you didn't remember which one type 4 was. So remember, in a patient who has hyperkalemia, the causes can be due to increased intake, cell shift, or decreased urinary K excretion. Generally, if the hyperkalemia is chronic, it's not due to cell shift. Cell shift causes usually acute and transient increases in potassium. Board questions are not going to be like what I present here. They're not going to all give you the 24-hour urine potassiums or the full workup. Oftentimes, you're just expected to use a little bit of clinical acumen. But in this particular patient, there's a good chance that they might be taking in too much potassium. It's certainly, they have all of these causes of decreased urinary potassium excretion. So this patient has renal failure. She is on an ACE inhibitor, and patients with diabetic nephropathy, which is what this patient most likely has. Remember, she has 4.8 grams of protein in the urine, which is nephrotic syndrome, so probably has diabetic nephropathy. Patients with diabetic nephropathy and mild CKD frequently have hyporeninemic hypoaldosteronism, which is a form of type 4 renal tubular acidosis. So that's probably contributing to this. And by the way, that's the reason why so many patients with diabetes and CKD get into problems with hyperkalemia, much more so than patients with CKD from other causes like hypertensive nephropathy. So this patient could certainly have a contribution from that. And as I mentioned before, patients with hyporeninemic hypoaldosteronism, although it's a form of type 4 RTA, they often are not acidotic, and as this patient was not. So that wouldn't deter me. So reminding you, hyperkalemia, they can have a non-gap metabolic acidosis, but sometimes they don't have that at all. Mild CKD and diabetes, one of these disorders, or they're on NSAIDs. So this patient had multifactorial hyperkalemia, like many of our patients do. Next is a 20-year-old man with no past medical history and on no meds, who comes in with 1 week history of fatigue, nausea, vomiting, diarrhea, and acute abdominal pain. And his blood pressure is 80/60, heart rate's 110, temp 99.8, his abdomen's mildly tender. He's got a sodium of 124, K of 6.8, bicarb of 18, BUN creatinine of 19 and 1.1, and a 24-hour urine potassium was 5. Which one of the following tests would be most likely to reveal the underlying cause of the hyperkalemia? Is it a blood DIG level, serum CK, ACTH stimulation test, blood glycosylated hemoglobin, or an iothalamate GFR test? Okay, good. So most of you chose an ACTH test. Few of you chose a CK. Interesting. So this patient obviously had decreased urinary K excretion, so 24-hour urine potassium was inappropriately low in the setting of hyperkalemia, less than 40, and therefore the differential is as shown. The patient wasn't on any of these meds, did not have renal failure, could have been a little volume depleted, but not enough to cause hyperkalemia by itself. So one has to wonder whether the patient didn't have any disorder that's normally associated with hyporeninemic hypoaldosteronism. So you should certainly want to suspect adrenal insufficiency. So patients that present with Addison's generally tend to be hypotensive. They tend to present with nonspecific symptoms like abdominal pain, nausea, and vomiting. They're hyperkalemic, their sodiums are low, and as in this patient, the BUN to creatinine ratio was, I think, a little elevated. So the clinical picture is most consistent with adrenal insufficiency, and so measuring a baseline cortisol and or doing an ACTH stimulation test would probably be a good idea in this patient. Don't think there's anything specific that would suggest rhabdomyolysis, although I don't think it's unreasonable to screen with a CK in a patient with hyperkalemia. That certainly wouldn't be the first thing I would think of. Moving on to number 7. This is an 18-year-old female who presents with acute muscle weakness, and she has had several previous episodes that resolved spontaneously. Her blood pressure is 96/54, and the rest of the exam was pretty unremarkable. And what you can see is that her serum potassium is 2.9, her bicarb is 28, BUN creatinine looked pretty normal, 24-hour urine shows a sodium of 40, potassium of 45, chloride of 95. Which of the following diagnoses are compatible with this clinical picture? Is it Gittleman's, primary hyperaldo, surreptitious amiloride use, surreptitious laxative abuse, or hypokalemic periodic paralysis? This turns out to be an exception. This is not hypokalemic periodic paralysis at all, but a case of potentially Gittleman's, and I'll explain to you why. So this patient had a very high urinary potassium, a lot higher than 25. So this was a case of urinary potassium wasting. Remember, if you have a patient that's hypokalemic periodic paralysis, they would, the normal response to the kidney is to try and conserve potassium, okay? the kidney would be normal if this was hypokalemic periodic paralysis, and so the urine K should be very low. This patient had a high urine K, so that's not the case. So this is a case of urinary K wasting. And these are the causes of it, but remember that the most common ones, when you can't figure out what the cause is, are going to be diuretics, vomiting, or Bartter/Gittleman, okay? So you can tell if a patient has a renal tubal acidosis of this proximal type 2 or a classic distal type 1 because they would usually have a non-GAMP acidosis. I think we would probably know if they were on most of these drugs, except maybe glue sniffing, which could be surreptitious, but again, patients who sniff glue would have an metabolic acidosis. And there's nothing here to suggest an osmotic diuresis. So these are the most likely differentials. And here's the cheat sheet. So it's immediately obvious how you distinguish between them is by measuring the urine chloride. In the setting of surreptitious vomiting, the urine chloride would be low. So the urine chloride is being used as a marker of volume depletion due to extrarenal salt loss. Whereas in diuretic abuse or Barter's or Gittleman's, the urine chloride would be high, reflecting the fact that the salt loss is in the urine. And this patient's urine chloride was extremely high. So that's the key to suggest that this patient is either abusing diuretics or has Barter's or Gittleman's. We can't really tell from the history which it is, and in clinical practice, this is often a really difficult problem distinguishing whether a patient is abusing diuretics or truly has Barter's or Gittleman's. And I should mention here that of these inherited disorders, what we're really talking about is Gittleman's. So Barter's syndrome is predominantly a disorder of infants. So if you see a patient with this who is an adolescent or an adult, it's going to be Gittleman's. And Gittleman's, by the way, is also much more common. Most of us will probably never see a case of Barter's, but we might run into a case of Gittleman's once in a while. So this could be either diuretic abuse or Gittleman's, and since diuretic abuse wasn't one of the options, Gittleman's is the one that's most consistent with the clinical picture. So next we have a case of a 74-year-old woman who was diagnosed with hypertension at the age of 40 and presents with worsening blood pressure control over the past 3 years. She's now on amlodipine, lisinopril, hydrochlorothiazide, atenolol, and clonidine. And her current blood pressure is 156/78. So she has resistant hypertension, which is defined as being on at least 4 doses of at least 3 antihypertensive meds, of which 1 is a diuretic. And her lab studies show that her sodium is 136, K is 3, creatinine is 2, BUN is 18, plasma renin activity is 8.5 nanograms per mil per hour. So most of you will have labs that report renin in this way as a concentration per hour. So this is the activity of the renin enzyme. Some of you will have labs now that report the new assay of renin concentration. But regardless, you can look at the normal range, and here the renin is high. And the plasma aldosterone level of 24 is also a little high. Which of the following tests would be the most appropriate? Next step. Is it CT scan of the adrenal glands, DEX suppression test, urine diuretic screen, Doppler ultrasound of the renal arteries, or a fecal laxative screen? So 83% of you wanted a Doppler ultrasound of the renal arteries, which is probably what I would want. So the finding of hypertension, particularly resistant hypertension, which suggests a secondary cause, in the setting of hypokalemia should alert you to the possibility of hyperaldosteronism. The main differential for the most common conditions is shown here, and you can easily sift through this by looking at the renins and aldos. If you had primary hyperaldo, the aldo is high, but the renin is low, and the ratio of aldo to renin is high. So generally, you suspect primary hyperaldo if the plasma renin activity to plasma aldo concentration is greater than 25 to 30. Here, our aldo to renin ratio was actually about 3. So clearly, this is not primary hyperaldo. In Cushing's, both aldo and renin are low. But this patient obviously had both a high renin and a high aldo, and this suggests this is secondary hyperaldosteronism, that the decreased perfusion of the kidney and renal artery stenosis drove high renins, which in turn drive high angiotensin II and aldosterone levels. And so there are, as you know, 2 types of renal artery stenosis. The rare type caused by fibromuscular dysplasia, which occurs in young adults, often female, and the common type, and we don't really know for sure exactly how common it is because it's probably underdiagnosed, but the common type, which is atherosclerotic renal artery stenosis, which occurs in older adults who are vasculopaths, and can cause both new hypertension in old age or can cause an abrupt worsening of hypertension in a patient who previously had essential hypertension. And so that's something that you should be alert to. And so the diagnosis of renal artery stenosis can be made a variety of ways. One way is to do a Doppler ultrasound. If they have relatively preserved renal function, you can do an MRA. And those are probably the most common ways of looking for that. So renal artery stenosis was the cause there. Okay, number 9. A 28-year-old man is found unconscious in the street and brought into the ER, has no medical history. His rests were 12 per minute. He appears disheveled and comatose, responsive only to pain. His pupils are reactive to light, but non-focal, no fetor. He gets gastric lavage and activated charcoal, and these are his initial labs, which are notable for a bicarb of 10. Rest of his labs are as shown. Creatinine is 1.6. And the rest of his workup includes an arterial pH of 7.22, PCO2 of 24, and a workup negative for ethanol, ketones and acetase, beta-hydroxybutyrate, lactate, salicylate, normal CK, and a serum osmolality of 308. So the question is, the most appropriate next step in the management of this patient should be dopamine, hemodialysis, forced alkaline diuresis, thiamine, or fameprazole. Okay, so a little bit of a split decision. 47% of you said hemodialysis. That's interesting. It's not the correct answer here, but if you answered it for the right reason, we could maybe give you half a point. But those of you who chose fameprazole, that's correct. C is wrong. Sorry, you don't get anything for that. Okay, so let's work through this. This is how I would approach this case. So the first is to approach the acid-base balance. So the patient has a pH of 7.22, so the patient is obviously acidemic. So I go and look at the PCO2 and the bicarb to see whether this is a primary respiratory or metabolic acidosis. Since the bicarb is low, this is obviously a primary metabolic acidosis. So the predicted compensation from a metabolic acidosis is that you would have a reduction in your PCO2. Remember, you would have Kussmaul's breathing, and your PCO2 should be reduced. In fact, this PCO2 is indeed reduced down to 24. And remember, as we discussed, when you have compensation, it should not return your pH all the way back to normal. And that's the case. The pH is still low. So this looks like a compensated primary metabolic acidosis. Do we know exactly whether it's fully compensated? If you want to know for sure, you have to plug the numbers in the formula, which I've shown you here. But as I said to you, for the purpose of the boards, generally you would not be expected to have to do this. If you're smart and you know this formula and can plug it in, that can sometimes help give you the upper hand in an exam, because when examiners design these questions, they're using these formulas to make sure that their questions make sense. So those of you who happen to have learned Winter's formula, that's a formula that people often use to calculate the PCO2 expected in metabolic acidosis, and it's 1.5 times the bicarb plus 8. That's all it is. So 1.5 times the bicarb of 10 is 15 plus 8 is 23, which is almost exactly what the PCO2 is. So this is consistent with a pure metabolic acidosis with just appropriate respiratory compensation. Next step, what's the anion gap? So the anion gap here is 132 minus 98 minus 10, which is 24, which is well above normal. So this is obviously an anion gap metabolic acidosis. I'm not going to go into the delta-delta. I'm sorry I have that here. For those of you who might have learned this before, this is sometimes a way of getting a clue as to the appropriateness of the compensation again. But for the purposes of the boards, you do not need to know this. You are not expected to be able to have to calculate this to figure out the problem. And so if you don't already know this, I would suggest that you don't worry too much about it and focus on the next step, which is to measure the serum osmolar gap to differentiate between the different forms of anion gap acidosis. And that is important. And so in this particular patient, we first calculate the serum osm, 2 times the sodium plus the glucose over 18 plus the BUN over 2.8. And you don't have to calculate this exactly. You can guess this is probably about 3, this is probably about 10, and this is 264. So that's going to be around 280s. So clearly much lower than the actual measured serum osm, which in this case was 308. So the osmolar gap is 28, normal being less than 10. So this is an osmolar gap metabolic acidosis. So the differential of an osmolar gap and an anion gap acidosis is ethanol with alcoholic ketoacidosis, ethylene glycol, propylene glycol, or methanol. Propylene glycol would only happen in a patient in the ICU on Ativan drip, so that's not the case. This patient didn't have ethanol and most importantly did not have ketones. So it's between ethylene glycol and methanol. Fortunately, the initial treatment of both is exactly the same, which is you want to block the metabolism of ethylene glycol and methanol to its toxic metabolites, which are glycolic acid and formic acid. And the way we block it is by inhibiting alcohol dehydrogenase, which is the enzyme that does that. And we do that either by giving these patients ethanol, which you can do, or by treating them with the drug fomepizole. Fomepizole works better, although it's a lot more expensive, but it's the first thing you should do. Now, patients who have severe ethylene glycol or methanol poisoning may well need hemodialysis to remove that toxin. But the first step is not hemodialysis. The first step is to first block the generation of toxins immediately with fomepizole. And so that's why fomepizole is really the correct answer. Hemodialysis would be a next step once you treated the patient with fomepizole if their levels of the drug of the toxin were high enough. So that's the answer in this case. Okay, number 10. An 18-year-old female is brought in with change in mental status and suspected toxic ingestion. Her blood pressure is 100/73, pulse rate 89, respiratory rate 40, temperature 100.5. She vomited once in the ER and is poorly responsive. And her labs are as shown. Bicarb is 26, creatinine is 1.8, serum glucose 62. And acid test is negative. Serum lactate is 1.8, serum osmolality 295. pH 739, PCO2 25. Which of the following treatments would be most likely to be effective in the management of this patient? Is it breathe into a bag, insulin drip, forced alkaline diuresis, 5% dextrose, or fomepizole again? And it's not unknown for examiners to give you the same answer to 2 consecutive questions. And yep, so the audience is always right. C, half of you chose that. Quarter of you chose E. Interesting. It's a whole selection here. So C is probably the best answer. Some of these answers are possible, but some of them are less likely. So let's work through it. So here's a patient whose pH is almost completely normal. So remember, why is the pH normal? It's either because the patient doesn't have any acid-base disorder, which clearly is not the case, or they have two counterbalancing acid-base disorders. So right off the bat, you know that this patient with a low bicarbonate has to have a primary metabolic acidosis, and a low CO2 must have a primary respiratory alkalosis. Okay? If he just had one, if he just had the metabolic acidosis, the PCO2 shouldn't be so low that the pH has returned to normal. And if the patient just had a primary respiratory acidosis, the bicarb should not have been lowered so much that the pH has returned to normal. So this has to be two disorders: primary metabolic acidosis and a primary respiratory alkalosis. Okay? If you want to plug in the numbers, you can calculate the compensation, not really necessary in this case. So let's focus now on the metabolic acidosis just for a minute and calculate the anion gap. Sodium minus the chloride and bicarb, it's 24. So this patient also has an anion gap metabolic acidosis. So the question here is, what causes an anion gap metabolic acidosis and a primary respiratory alkalosis, and also causes fever and tachycardia, as this patient had? And the most common cause, we'll ignore the delta-delta again, not really required here. Let me just mention, just to dismiss this, that it's a good practice in this patient to measure, to calculate the osmolar gap. So you calculate the serum osmolality, it comes out to 295. The osmolar gap is therefore 0 because the measured serum osmolality was also 295. So this is not an small alcohol poisoning. So the most likely cause, normal osmolar gap, positive anion gap acidosis, and an intoxication in a patient who's tachycardic, febrile, tachypneic, and also has a primary respiratory alkalosis, is classic for salicylate poisoning. So that's the diagnosis. You also need to know one other piece of information, which is how to treat salicylate poisoning. And the two main ways of getting rid of it, other than obviously GI decontamination, are either forced alkaline diuresis or hemodialysis. And so forced alkaline diuresis is the correct answer because that would get rid of salicylate. And the reason it gets rid of it is because salicylate is a weak organic anion, and so when you alkalize the urine, you protonate the salicylate, you deprotonate the salicylate and prevent it from being reabsorbed back from the urine. So the salicylates are probably the most common intoxication for which alkaline diuresis is used. And let's just check what the other options were to see if there was a reason. Okay, so breathing into a bag would be appropriate if this were just a primary respiratory alkalosis due to anxiety, which is unlikely to be the case here. Insulin would be appropriate for DKA, which this obviously isn't. 5% dextrose is not an inappropriate treatment, but it's not going to correct anything, except in the case of a patient with ketoacidosis. Dextrose is useful. That's not the case here. And as we mentioned, there's no indication here for methanol or ethylene glycol poisoning. So fameprazole would not be indicated, and you'd be wasting a large amount of your hospital's money. So number 11. A 35-year-old male with HIV infections maintained on heart therapy. His regimen was lopinavir, ritonavir, tenofovir, and lamivudine. And he's been doing well, but when he comes into clinic, his chemistries are all out of whack. Unfortunately, you're left to figure out why. And you see that his serum potassium is 2.8, bicarb is 18, creatinine is 1.7. Let's see, phosphate is 1.8. So urinalysis is as shown. And so the question is, which of the following would be the most appropriate next step in the management of this patient? Is it stool micro and colonoscopy, discontinue tenofovir, discontinue lopinavir, send an autoantibody panel, or MRI of the adrenal glands? Okay, good. So 80% of you chose B, which is in fact the correct answer. The few of you that chose C, it's probably because you didn't recognize, you either know it or you don't know that tenofovir causes this syndrome. Okay, and we'll go over what this syndrome is. So this patient has a bicarb of 18. They don't give you the ABG here. Very common in board questions. They're not going to give you every piece of information. You have to use a little bit of clinical guesswork. And you're going to guess that this is probably a metabolic acidosis. And therefore, since the anion gap is 8, that this is a non-gap acidosis. Okay? So the differential is obviously diarrhea versus renal tubular acidosis. The clue here is that the urine pH is 6. Remember, in the setting of a metabolic acidosis, the kidney responds by attempting to acidify the urine and get rid of acid. So urine pH of 6 is always inappropriate in the setting of metabolic acidosis, and so that points you to renal tubular acidosis, and actually points you to 2 possible types of renal tubular acidosis, type 1 and type 2, and pretty much excludes type 4, although type 4 you wouldn't expect anyway, because that's the hyperkalemic type. Okay, so this is either proximal or classic distal. Okay, and the reason that we included autoantibody screen here is if you thought this was a classic distal RTA, the most common cause is Sjogren's or lupus, and so an autoantibody screen would be appropriate. Now, a type 1 or proximal RTA, as I mentioned, is often quite difficult to diagnose and differentiate from the other RTAs. There are a lot of esoteric ways of dissecting these out that as an internist you would not be expected to know or have to do. But fortunately, we do know that almost all patients that present as adults of proximal RTA do so as part of Fanconi syndrome. And so if you see, as in this patient, hypokalemia, hypophosphatemia, and particularly hypophosphatemia despite renal insufficiency, and glycosuria despite having a normal serum glucose, which is abnormal, that would clue you in that this patient has Fanconi syndrome with a type 2 or proximal RTA. Okay? So why does this patient have Fanconi's? You would have to know that a common cause of Fanconi's is tenofovir, which this patient was on. And so stopping the tenofovir is the appropriate treatment in this case. Okay, number 12, moving on. A 47-year-old female with known peptic ulcer disease presents with 3 days of epigastric pain, profuse vomiting, and inability to tolerate oral fluids. On exam, she's in moderate pain, blood pressure is 88/42, pulse rate 97, mucous membranes are dry. So her sodium is 124, K is 3, bicarb is 40, BUN 56, creatinine 2.1, lactate 8.3, pH is 7.65, and PCO2 is 38. Which of the following best describes the acid-base disorder in this patient? These sorts of questions are beloved of board examiners to ask you how many acid-base disorders there are. And so you can see the various combinations. So pick one. Okay, so this was a challenging one. This may be slightly harder than what you would get in the boards. The correct answer is, in fact, D. Those of you who picked B were quite close, but there was included a little bit of a cryptic clue, if you will, that indicates that this is D. So the first thing is to look at the arterial blood gas, and obviously this is an alkalemia. and because the bicarb is high, we all recognize this as metabolic alkalosis, exactly what we'd expect in a patient with profuse vomiting. But at the same time, we would expect that if this was simply a simple primary metabolic alkalosis, we would expect that there would be respiratory compensation. In other words, that the ventilation rate would be reduced to allow the PCO2 to rise to correct the pH. In fact, that's not happened. If anything, the PCO2 is a little bit low. So without having to look up any tables or charts or anything, you automatically know that this patient must also have a primary respiratory alkalosis. And presumably it's just because the patient's in pain, common cause of respiratory alkalosis. The other clues here are that the patient actually has an anion gap, and the patient has a lactate level of 8.3. So you pretty much know that this patient has to have a lactic acidosis, and that's presumably because of the hypotension and decreased tissue perfusion. So what we have here is 3 disorders: metabolic alkalosis, respiratory alkalosis, and a metabolic acidosis from lactic acidosis. So this is actually a triple acid-based disorder. Those of you who just got these 2 can give yourself, I don't know, 2/3 of a point, okay? Okay, number 13. A 22-year-old female presents with fatigue and generalized muscle weakness. Blood pressure is 92/65, heart rate 62, weight 60, height 5'9", and her labs are remarkable for a K of 3.3, bicarb of 32, creatinine 0.6. ABG shows a pH of 7.46, PCO2 47, urine sodium is 15, potassium 36, and chloride less than 5. So the question is, what's the likely cause of this patient's acid-base disturbance? Is it surreptitious vomiting, laxative abuse, thiazide abuse, Gittleman's, or hepatic encephalopathy? Okay, good. So most of you chose A, which is in fact the correct answer, surreptitious vomiting. So working through these, so you can, some of these complicated cases, you can approach them from several angles. We're going to approach this first from the acid-base angle. So this is a patient who is alkalemic and obviously has a metabolic alkalosis. If you look at the PCO2, it is elevated, which is what we would expect as respiratory compensation. So this would be consistent with a simple primary metabolic alkalosis. Okay? Here's the differential diagnosis. Most of these are, by the way, associated with hypokalemia. And when you don't know what the cause is, it's not obvious from the history, the chances are the patient's either surreptitiously vomiting, surreptitiously abusing diuretics, has Barters and Gittleman's, or they have hyperaldosteronism. Okay? If you're hyperaldo, you would expect the blood pressure to be high. This patient's blood pressure is not high, it's actually low. The other clue is this patient is obviously quite tall and thin, so you should certainly wonder whether this patient has some sort of body image disorder and is secretly abusing diuretics or has bulimia, as you know, pretty common in our society nowadays. And the clue here, as before, is the urine chloride. And in this case, the urine chloride was profoundly low, and that suggests that this is a patient who has extra renal volume, loss of salt causing volume depletion, and in the setting of hypokalemic metabolic alkalosis, this usually means that this patient is surreptitiously vomiting. So that's the most likely disorder cause in this patient. So now we're on to our quick fire round, where we're going to ask you for a bunch of answers to stereotypic situations. And again, this is taken directly from the structure that multiple choice questions are formulated for the boards. This is exactly how you would expect a board question to appear. So first one is a 22-year-old male with no past medical history presents with confusion. His serum sodium is 106. osmolality 240, urine sodium 45, urine osmolality of 40. And the question is, what's the best option for treatment of the patient's serum sodium? Is it isotonic saline, hypertonic saline, free water restriction, hydrocortisone, or you shouldn't treat? Okay, interesting. So most of you actually chose hypertonic saline, and some of you chose free water restriction. Okay, so if you chose hypertonic saline, you can get half a point. C is probably the correct answer here. And maybe this depends on how you pass the term confusion. So the important thing here is this is a patient who's hyponatremic and hypoosmolar, but has a very low urine osmolality. So as we discussed, the only way you can get a low urine osmolality and still be hyponatremic is if you're drinking water faster than you're peeing it out. In other words, psychogenic polydipsia. And in psychogenic polydipsia, these patients are drinking large amounts of water, maybe a liter an hour at a time, or maybe even more, and they're peeing out urine very fast, maybe even a liter an hour or more. So if you just stop them from drinking and they continue peeing out this very dilute urine, their serum sodium will come up spontaneously. In fact, sometimes it comes up too fast, which can be a cause for concern. So this patient would not need hypertonic saline. I can understand why some of you answered hypertonic saline, because as I mentioned, if you have a patient of acute hyponatremia and they have symptoms, particularly if they have seizures, you might want to raise the sodium quickly. But in the setting of psychogenic polydipsia, the sodium comes up very rapidly of fluid restriction. So we would not normally give hypertonic saline at all to a patient with psychogenic polydipsia. And that's why C is the correct answer. Okay, number 15, another case of hyponatremia. This is a 52-year-old female with COPD, 2 months of dyspnea. She has a seizure, and when she's examined, she's confused. Her clinical exam looks euvolemic. Serum sodium is 110, serum osm 251, urine sodium 150, urine osmolality of 710. What's the best option for correcting her hyponatremia? Okay, good. So this time hypertonic saline is the correct answer, as you quite rightly pointed out. Those of you who chose A, normal saline, could probably get half a point for that. So basically, this patient probably has SIADH, so hypoosmolar hyponatremia in a euvolemic patient. If we give you a clue like they have COPD, we're probably trying to suggest to you that they have small cell carcinoma and hyponatremia, which is one of the most common causes of SIADH. The other clue, if you happen to be savvy enough to notice this, is that patients whose urine osmolalities are this high, greater than about 500 or 600, usually have SIADH. The other causes don't usually make your urine osmolality that high. So this patient obviously has symptoms. The patient has a seizure, so you really want to bring up the sodium a little bit, but quite quickly. Normal saline is not the correct answer, and the reason is because when you give isotonic saline to a patient whose urine is this concentrated, so you can see the urine sodium is already quite high, they actually can pee out the sodium faster than you can give it. In fact, this patient's urine osmolality is substantially higher than the osmolality of the isotonic saline that you're getting in. And so there's actually a phenomenon that you won't get in the boards, but you should be aware of as internists, called desalination, where a patient with this concentrated urine, when they get given isotonic saline, they'll actually pee out sodium faster than it goes in, and the serum sodium will actually fall rather than rise. So the lesson from this is if you have a patient of SIADH and a very concentrated urine, you need a very hypertonic solution to correct it. And that's why 3% saline is the appropriate treatment in this patient. All of these others would not, so hydrocortisone obviously wouldn't do anything. And free water restriction is appropriate chronic treatment for SIADH, but isn't going to bring up the sodium fast enough in a patient who's having seizures. Okay, number 16, a 67-year-old male with fatigue and low back pain. Serum values were sodium of 124, glucose 76, total protein of 13, albumin of 3.6, hemoglobin of 9. Best option for treatment of this serum sodium. Okay, good. Most of you noticed this was a trick question. So I didn't give you the plasma osmolality, but whenever you see an elderly person with fatigue, low back pain, a very high total protein, and anemia, you got to suspect myeloma, right? And in the setting of having a total protein that's extremely high, there's the possibility that this hyponatremia could be pseudohyponatremia. Now, some of you may have hopefully read in the textbooks that pseudohyponatremia is quite rare now because most labs don't measure the serum sodium with the old method, which is flame photometry. We now use iron-sensitive electrodes. Turns out, though, that depending on whether the serum that's sent to the lab is diluted before you measure it, which we call indirect potentiometry, or not diluted, which we call direct potentiometry, you can still get pseudohyponatremia. So whenever you get a case like this and you know the total protein is high, it behooves you to call the lab and find out what's the method that was used to measure the serum sodium, and could this be pseudohyponatremia, which is the most likely thing in this case. And so if it's pseudohyponatremia, you wouldn't treat it. Obviously, in practice, you would measure the plasma osmolality and make sure that you are right about this. Number 17, a 45-year-old male with diabetes, mellitus, hypertension, ischemic cardiomyopathy, is on aspirin, carvedilol, captopril, glipizide, and furosemide. On exam, his mucous membranes are moist. He's got JVP to the angle of the jaw, 3+ pitting edema, serum sodium 123, urine sodium is 10, and urine osmolality is 570. What's the best option for treating this patient? Okay, so everyone agrees that this would be free water restriction because this is chronic hyponatremia, not acute. And patients with CHF don't usually get acute hyponatremia. This might also be a candidate for Vaptan, like tolvaptan, as we mentioned earlier this morning. It's kind of controversial what the potential indications are for Vaptans, but a patient with chronic hyponatremia like this, if the patient were resistant to fluid restriction, and if you believed that the chronic hyponatremia was detrimental, which more and more people are beginning to realize, you'd probably be reasonable to give this patient tolvaptan. The other thing that I should mention practically is that when we say free water restriction, we usually mean fluid restriction. So firstly, patients don't really have any clue what free water means. And secondly, almost all the fluids that patients take in are essentially hypotonic fluids. So you don't really need to distinguish between them. The only exceptions are your grandmother's very salty chicken soup, which could be isotonic. But even something like Gatorade or other sports drinks, those have some salt in it. So they're not completely free water, but they are hypotonic. So in general, when we say free water restriction, what we're usually telling the patients to do is just restrict the total amount of fluid they take in, whether it's water, coffee or tea, or juice. Okay, number 18. A 43-year-old man with type 2 diabetes, hypertension, CHF, nephrotic range proteinuria, peripheral edema, and the serum creatinine of 1.6. Serum potassiums are usually in the range of 5.3 to 5.6 since starting captopril and despite adhering to a potassium-restricted diet. And the question is, what's the best option for treating the high serum potassium? Is it a thiazide diuretic, hydrocortisone, insulin, hemodialysis, or sodium polystyrene sulfonate, which is Kexlate? Okay, so there's a little bit of discrepancy. Most of you chose A, which I personally think would be the best answer. Some of you chose E, which you can get half a point for that. So this is a patient who has hyperkalemia, probably from at least two causes. One is obviously having renal failure, and the other is, as I mentioned, patients with diabetic nephropathy frequently develop hyporeninemic hypoaldosteronism. I actually got a question in the break about whether one might treat hyporeninemic hypoaldosteronism with fludrocortisone, which is logical, but most patients with hyporeninemic hypoaldo tend to be hypertensive and volume overloaded. So this patient has both hypertension and CHF and peripheral edema. So fludrocortisone would correct the potassium, but it would actually make the hypertension volume overload worse. What does help in these patients get rid of the potassium is to give a potassium-losing diuretic, which, if the GFR is relatively high, is a thiazide diuretic, and as the GFR falls, you might consider a loop diuretic. Kayexalate, as we mentioned earlier this morning, is appropriate acute treatment for hyperkalemia. So if this patient came into the ER with a K of 6.5, I would certainly give him a dose or two of Kayexalate. Chronically, we don't tend to give Kayexalate for chronic mild hyperkalemia. Sometimes we do, so I've certainly had patients who I've given 5 to 10 grams of Kayexalate daily to keep their potassiums down. But those patients need to be monitored very closely, usually weekly or every 2 weeks in clinic. And as we mentioned this morning, we're increasingly recognizing that this could be associated with complications like colonic necrosis. We just don't know what level of risk we're exposing our patients to. But elderly vasculopaths, I would definitely avoid doing this in. So I personally think A would be the best treatment here. Okay, number 19, 88-year-old woman who had a partial sigmoid colectomy for perforated diverticular abscess and septicemia 2 days previously and has been anuric since the operation. Serum K is 6.5, there are no EKG changes. What would you do? Okay, so most of you picked D. Some of you picked E, and there's a practical reason why not. So obviously this patient is hyperkalemic because the patient has anuric acute renal failure. In the absence of EKG changes, it's not urgent to bring down the potassium immediately. I don't think it's unreasonable to give some insulin or insulin and glucose. It's obviously not the definitive treatment for this patient. The definitive treatment is to remove the potassium. Hydrocortisone is not going to do it, and they're obviously not going to respond to diuretics if they have renal failure. The reason this Kayexalate is not correct is because this is a patient who's 2 days post-sigmoid colectomy, and so they probably won't want to give anything either PO or per rectum. And so probably the best thing to do, especially since the patient is also anuric, is to dialyze the patient. And that's why hemodialysis is probably the best answer in this case. And I should mention that when you dialyze a patient, the serum potassium comes down probably sometime the first hour or two. So it's not immediate. So you need the time to have the dialysis nurse come in, wheel in the machine, start the dialysis, and then wait at least half an hour to an hour or so before the serum potassium starts to progressively come down. And then by the end of 3 to 4 hours, the potassium will be usually down to normal, depending on how the dialysis prescription's been written. Okay, another patient with hyperkalemia. This one is a young man who presents with a week of polyuria and polydipsia, and his K is 5.9 with a glucose of 330 and a creatinine of 2.2 and a bicarb of 16. Okay, we're pretty close. Okay, so obviously this is a patient who probably has diabetic ketoacidosis. They're hypoglycemic. They probably have a metabolic acidosis. In the setting of DKA, patients usually are whole body potassium depleted because they have chronic osmotic diuresis for at least the preceding week or so, but they have a shift of potassium out of the cells into the plasma, and that's why they're hyperkalemic. So the appropriate treatment is to restore the potassium into the cells, which is what the insulin would do, which you would give anyway for DKA. But bearing in mind that when you treat them with the insulin, this will then uncover the underlying whole body potassium deficit. So as you treat them with insulin, they go from hyperkalemic to normal and then rapidly often to become hypokalemic. So you have to recognize that problem and be ready to give them back potassium shortly after you start the insulin as their serum potassium starts to drop. Number 21. 26-year-old woman with AIDS, fatigue, weight loss, low-grade fever, and orthostatic hypotension. And her serum cortisol level is 7 at base in the morning, and after giving an ACTH analog, it goes up to 10 and then 11. What's the best treatment for her hyperkalemia? Okay, and so everyone agrees that it's going to be hydrocortisone. So this is obviously a patient whose cortisol level couldn't be raised above 15, even with cosyntropin. So this patient has AIDS associated with adrenal insufficiency. And when you give these patients hydrocortisone and fludrocortisone, but even with hydrocortisone, the potassium will be corrected. And then the final few items are hypokalemic metabolic alkaloses, and you have to select the most likely cause. We had several of these already, so this should be a slam dunk for you. 16-year-old girl with amenorrhea, body mass index of 13, and a urine chloride concentration of 5. All right, so some A and some mostly B. So obviously a patient who's this thin and amenorrheic probably has anorexia. They could be abusing diuretics. They could be surreptitiously vomiting. The clue here is the urine chloride of 5, which is very, very low and suggests extrarenal salt loss. So this patient in this case was surreptitiously vomiting. This is a 35-year-old man presenting for the first time with new onset hypertension, and he has hypokalemic metabolic alkalosis. What do we think is the likely cause? Okay, and most of you chose Conn syndrome. Some of you chose diuretic use. Interesting. Oh, okay. So maybe it's the way I would, well, I said new onset hypertension, so you should know that the patient, assume the patient wasn't being treated. So hypertension and hypokalemic metabolic alkalosis suggest a patient who has hyperaldosteronism. And the most common cause of hyperaldosteronism is in fact primary hyperaldosteronism or Conn syndrome, which is an increasingly recognized cause of secondary hypertension. People nowadays think that maybe as much as 10% of patients who present with hypertension actually have primary hyperaldo. So it's worth picking up because some patients have unilateral causes like unilateral adrenal hyperplasia or adenoma, and so can be cured of their hypertension by having surgical treatment. Number 24, a 32-year-old woman who has a known history of bulimia, and she comes in with hypokalemic metabolic alkalosis and has random urine chloride concentrations on 3 separate clinic visits, and they're clocked in at 40, 67, and 26. Okay, good. So most of you chose A, which is diuretic use, which is probably the most likely. So patients who have bulimia and anorexia also abuse diuretics. So that's the point here. And the clue is the urine chloride concentration, which is high. In patients who are abusing diuretics, the urine chloride can vary because obviously on different visits they may or may not be taking their diuretics. So depending on when you catch them, the urine chloride can be high or low. and that's one of the clues we use to picking up diuretic abuse. If you just took one value of the urine chloride and you didn't know that this patient had bulimia, sure, the numbers could be consistent with Gittleman syndrome, but the whole clinical picture looks much more like diuretic abuse. So that's why A is the best answer. A 15-year-old girl with recurrent episodes of muscle weakness since childhood and a urine chloride of 65, 24 urine K is 60, and her brother has had similar symptoms. Okay, interesting. So divided equally between C and D. So here's hypokalemia. The 24-hour urine potassium concentration is very high, 60. Remember, more than 40 is very high. Should be less than 25 in the patient's hypokalemic. If this were hypokalemic periodic paralysis, you would expect the urine's potassium to be very low. Okay, so even though this is clearly an inherited disorder, because a brother has similar symptoms, this is not an inherited hypokalemic periodic paralysis. Rather, with a high urine chloride, this is probably Gittleman syndrome. You may have been confused by the episodes of muscle weakness. Well, I'm sorry to have to tell you that all causes of hypokalemia, if severe enough, can cause muscle weakness. So in fact, even in Gittleman's, the typical history is of patients developing episodes of muscle weakness. And eventually someone measures the potassium and figures out that these muscle weakness episodes are caused by hypokalemia, but it doesn't mean they have hypokalemic periodic paralysis, which is a very specific syndrome that this patient does not have. And then lastly, a 20-year-old man with thyrotoxicosis and recurrent episodes of muscle weakness after meals, and he has hypokalemia. Okay, good. So all of you got the correct answer. This time it truly is hypokalemic periodic paralysis. The other thing I should mention is that in general, hypokalemic periodic paralysis wouldn't really cause significant alkalosis. So that's another distinction that you can use. But this is clearly a classic case of a patient with acquired hypokalemic periodic paralysis. And when you treat the thyrotoxicosis, the syndrome usually resolves.
Patient presents with symptoms and signs suggestive of UTI and has gross hematuria. Does this warrant workup for urologic malignancy? Urinalysis has some blood, what to do? Certainly urinary tract infections are quite common, and in a certain percentage of cases you can see gross hematuria. I think depending on the age of the patient, other risk factors, whether they're a smoker, et cetera, I would have a lower threshold for considering at least checking urine cytologies and or some non-invasive imaging such as an ultrasound. If the urinalysis has some blood, what to do, sort of an extension. Again, repeat it, make sure if it's in a woman, it's not related to menses or underlying urinary tract infection. Asymptomatic hematuria, also very common, often benign. So the question becomes whether the patient deserves a screening ultrasound or other imaging. I think that probably is incumbent on us once you've documented the hematuria to at least do a limited urologic evaluation and cytologies. You could consider a 24-hour urine for calcium and get some insight as to whether there's proteinuria, because again, proteinuria indicating more renal origin as opposed to urologic origin.
Great, so maybe we'll switch to Alan. Any questions you want to answer?
Sure. I'll start off with a really challenging one that I got. Someone asked me, how does SIADH differ from cerebral salt wasting syndrome? And I didn't get into cerebral salt wasting syndrome because it's probably quite rare and unlikely that that would come up in the boards. There are patients, mostly patients who've had subarachnoid hemorrhages or other types of cerebral vascular accidents who present with hyponatremia. And just like in SIADH, they have very high urine osmolalities and high urine sodium. The difference is that they're volume depleted. So the cause of their hyponatremia is that they're losing sodium in the urine, whereas the cause of SIADH is they're retaining water in the urine. So the diagnosis of cerebral salt wasting, if you happen to be fortunate or unfortunate enough to encounter it, is made by demonstrating that if you don't replete fluids enough, the patient becomes volume depleted and they continue to waste sodium, meaning that the urine sodium is persistently high. Whereas in SIADH, they don't tend to be volume depleted. In fact, they tend to be on the volume replete side. Let's see, there's a question here, is water restriction necessary with a normal plasma sodium in a patient or CHF? I don't think so. If patients truly have congestive symptoms, what they really need is sodium restriction. If you restrict sodium in a patient, they will, and they're not hyponatremic, they will automatically regulate their serum sodium osmolality appropriately, meaning that they'll drink less water and have less expansion of the extracellular volume. There's a question here which I think reflects the fact that I didn't make myself clear. In the evaluation of electrolyte abnormalities like hypokalemia, do you necessarily have to have a 24-hour urine collection? And the answer is, and given the challenges of a 24-hour urine collection, and that's absolutely right. Most studies have shown that the majority of patients have a really hard time accurately collecting 24-hour urine. We gauge how accurate the 24-hour urine is by measuring the creatinine. So the creatinine excretion rate is fairly constant in any one individual and is dependent on gender and muscle mass, but is generally about 20 to 25 mg per kilo in a male, 15 to 20 mg per kilo in a female. So about a gram of creatinine excretion for a female. For the specific issue of urine chloride, I may have said this wrong, but what we're talking about is spot urine chloride for concentration. That's what we're looking at. So you don't need a 24-hour urine when you're using the urine chloride or the urine sodium to detect whether someone's volume depleted. Oh, and here's a question. How does excess IV fluids cause an acid-base disorder? In other words, hyperchloremic metabolic acidosis. So I skipped over this. In the differential of a non-GAP metabolic acidosis, you can get a mild non-GAP metabolic acidosis just from volume expansion, which we call a dilutional acidosis. You need quite a lot of normal saline, and essentially what this is really doing is diluting down the serum bicarb, so that you're giving sodium and chloride and water but not bicarb, so you're diluting down the bicarb, and that can cause a mild acidosis. Occasionally it's, for example, if we have burns patients who get liters and liters of saline, and sometimes you can see quite a significant acidosis from that.
Brad, a few questions.
So one question is, what is the present role for direct renin inhibitors, aliskiren, in the management? It doesn't say a management of what, but I assume hypertension and/or proteinuria. So the direct renin inhibitors are certainly in the same pathway as the ACE inhibitors and the angiotensin receptor blockers. Most of the recent data has suggested that combination therapy is not something we should be routinely doing in our patients, either for proteinuria control or for hypertension control. When I say combination, I mean combination of an ACE, ARB, or a direct renin inhibitor. Due to the cost and other factors, I only have had very rare patients on this, in part due to the lack of data that there's any advantage, and the ability to keep most patients on an ACE or an ARB.
So when you say don't you avoid combination, you mean a direct renin inhibitor and an ACE, or a direct renin inhibitor and an ARB, not just a direct renin inhibitor?
Correct. So and also ACE and ARB have all,
ACE and ARB, right.
combination have also are probably something we should not be doing on a routine basis for.
Right, and I think just to clarify, the data for that has not been published yet with the direct renin inhibitor, but there was a trial called the Altitude study, which was stopped by the Data Monitoring Committee in the past 3 months, where they were testing a direct renin inhibitor and an angiotensin blocker together, and that had greater number of renal endpoints than in patients and hypotension than in patients with just the single agent. And so that has sort of reinforced the notion of being cautious with the use of combination therapy. But I think the jury is still out. We probably need more data till the last issue has been settled on this. But right now the recommendation is don't use them. Is that right?
Right, and that's also consistent with the study that looked at ACE and ARBs together.
Right,
also,
exactly.
similar.
Yeah, keep going.
So sort of two IgA-related questions, slightly different focus. One is, do you treat proteinuria of IgA nephropathy in the absence of hypertension with normal BUN and creatinine? And you can actually generalize this. Should you treat any patient with proteinuria, no hypertension, and normal BUN and creatinine? And for the most part, my practice has been to say yes, and to try to get these patients on a renin-angiotensin inhibitor. Due to, particularly in an IgA patient, as this question indicates, there is good data that inhibition of the RAS system can delay progression, as it does in most proteinuric renal diseases. And the heavier the proteinuria, the bigger the benefit.
Can I ask you, what do you do in somebody with chronic kidney disease without proteinuria? Do you use an ACE or an ARB? What do you do there?
So I think the JNC7 guidelines, or anyone with chronic kidney disease, an ACE or ARB should be first choice. I think the new JNC guidelines are overdue and will be out later this year, we're told. I still use an ACE or an ARB as my first choice as the antihypertensive agent for a patient with CKD but no albuminuria. But I think the threshold for switching may be a bit lower than in those patients with documented proteinuria.
I think just to clarify this, since JNC7 is open season for the boards, that would probably be the right answer for the boards. There's some controversy about using ACE or ARBs in patients with non-proteinuric kidney disease, and the latest kidney guidelines on this issue on hypertension. So hypertensive patient with CKD without albuminuria, the latest guidelines that are just being published or will just be published say that it's not necessary, but I think JNC7, for the purposes of an examination, will trump this, and most people, most nephrologists, including myself, do exactly as Brad does, and that probably would be the right answer if they do ask you that in the boards.
And the other related point is that the cardiovascular risk for microalbuminuria actually begins to increase well within the normal range. Microalbumins of 10 up to 30, although technically normal, do predict increased cardiovascular risk. So there may be some other sort of rationale for the ACE inhibitor in that patient.
Okay.
In terms of the boards, how would we differentiate between IgA nephropathy and post-strep GN? So a very good question. Certainly upper respiratory infection can lead to post-strep GN and exacerbate underlying IgA nephropathy. First, the history, very important. Usually the gross hematuria episode in a patient with IgA will be quite temporally related to the infection within 12, 24 hours. Whereas post-strep GN requires a latency period of 7 to 10 days. So the development of edema or proteinuria in a patient with documented strep would be delayed. There are serologic markers that can help you. The ASLO titer will typically be increased in a patient post-strep, and you would not expect that in an IgA patient. And then finally, if we really are unsure, the kidney biopsy has a very different picture that is quite easy to distinguish.